All right, everybody. Here to tell us about cultural considerations in the Native American and Alaskan Native community during the perinatal period is Dr. Shoshana Maxwell.
Thank you very much, and it's wonderful to be here and wonderful to hear all of the stories and experiences that have been shared prior to myself. Well, a little bit about me. I'm a family medicine physician, and I work for NARA, Northwest, the Native American Rehabilitation Association. Yay. And I've worked for NARA for about 6 years now. Thank you. And before that, worked with the Puyallup tribe in Tacoma, Washington. And apologies in advance, you're going to see this photo a lot. It's my baby. Okay. I do not have any disclosures, no relevant financial relationships to disclose, and I will not be discussing any off-label use or investigational uses in my presentation. As far as objectives, all of the participants hopefully will learn how systemic racism, bias, and stigma impact American Indian, Alaska Native birth outcomes, learn common beliefs about substance use disorders and pregnancy in American Indian, Alaska Native communities, identify questions to ask and what behaviors are welcome, and also become more familiar with culturally specific providers in our community and how to access them. With that said, there are over 570 federally recognized tribes within the United States of America, and there's no way for me to cover all of them. And so really what the goal of this presentation is to give you, those working with the community, a foundation to begin culturally appropriate conversations and interactions with our community. In order to understand the roots of systemic racism for the American Indian Alaska Native community, it is imperative to be aware of the historical events and federal Indian policies that are listed here. I'm not going to read them all because I believe slides will be sent out, but these policies really do fall into two different categories. The first being those policies that were meant to destroy culture, and then those that were meant to preserve and uplift culture. In particular, boarding schools, which occurred anywhere from the 1860s to 1960s, and some still actually exist today, but they're under different names, of course. Through that time period, hundreds of thousands of Native children were forcibly removed from their homes by the federal government and local churches. This really had the goal of systemic destruction of Native culture and communities with the stated purpose of kill the Indian, save the man. And this, of course, contributed to destroying connection between children and their families, their cultures, and tribes. Then subsequently, the Indian Adoption Project from 1950s to the 1960s led to the placement of American Indian, Alaska Native children with white families through contracts between the Bureau of Indian Affairs and the Child Welfare League of America. Again, with the goal of assimilation and severance of tribal identity. It resulted in unnecessary removal of children from their homes, leading to loss of tribal and family connections, with a subsequent high rates of substance use, suicide, and mental illness. In response to these tragedies of the boarding schools and the Indian Adoption Project, the Indian Child Welfare Act was created in response to these targeted removal practices that disproportionately affected American Indian, Alaska Native parents. This law was established in 1978 And what it did was establish minimum federal standards for removal and govern any potential removal of Native children from their homes. It essentially gave tribal courts primary jurisdiction over child custody proceedings for Native American children living on a reservation or belonging to a federally recognized tribe. This included, this is a key term, placement preference with family and also with tribal members. And it also encompassed protections for parents regarding termination of their parental rights. Despite the Indian Child Welfare Act, Native children in Oregon were still being removed from their families at higher rates than non-tribal children. This led to the creation of the Oregon Indian Child Welfare Act not so long ago, 2021. I mean, COVID pandemic was, 2020, and so 2021 is really not that long ago. And this was instituted to ensure that the federal law was applied in this state of Oregon to increase consistency being followed by judges, attorneys, and child welfare employees. So these tables here, just to give you just some number data in regards to how well Oregon is doing in following the Indian Child Welfare Act. So the first table, table 5 there, shows the number of Indian childs that were placed with their extended family who were going through foster care. And you can see that number is 579, the grand total being 1,400. And of this group of 1,400, 300 were placed outside placement preferences, meaning they were placed in non-tribal homes or outside of their family, which is over 20%. And so in Oregon, we still have quite a lot of work to do. And the second table is in regards to adoptive homes, so those children who are being adopted. And as you can see, the total was around 60, but around half of that number, either there's no data or they're placed outside of tribal preferences. So there is much work that we still have to do here in the state of Oregon. Historical trauma encompasses emotions resulting from traumatic events such as boarding schools, the Indian Adoption Project, that can include anger, grief, low self-esteem, and anxiety and depression. Contributes to increased rates of substance abuse, postpartum depression, intimate partner violence, and more. It also contributes to reproductive injustices, which can include the right to have children, the ability to choose, conditions under which one gives birth, the freedom to parent children with support, safety, and dignity. Colonizers controlled motherhood for many American Indian Alaska Native women, which included forced abortions, forced sterilization, and the limitation of birth control access. And I know there's a lot going on in the slide, but for this presentation, just wanted to focus on really the infant mortality statistics in regards to these health disparities compared to non-Hispanic whites. And as you can see, 2 times greater rate of infant mortality for Native children, 2.7 times greater incidence of accidental deaths before 1 year of age, 2.8 times more likely to receive late or no prenatal care for American Indian Alaska Native mothers, and 70% more likely to smoke during pregnancy for our mothers. Regarding maternal disparities and inequalities, American Indian and Alaska Native infants faced a double risk of death compared to white infants, and during pregnancy, Native women faced a risk of death 2 to 3 times higher than their white counterparts. In addition to facing higher rates of postpartum depression, worsened by forced removal of children from homes, erasure of culture, and medicalization of birth from unnecessary procedures, some of which would be C-sections that weren't medically indicated. And also a 3-fold increase in drug-related deaths in pregnant and postpartum individuals. This table here outlines the rates of sudden infant death syndrome and sudden unexpected infant death syndrome in the United States, New Zealand, and for different cultures. As you can see, American Indian Alaska Natives are at the top for SIDS and sudden unexpected infant death, and are more than double the United States average. In addition to the tragedies from the boarding schools that led to historical trauma, 27% of American Indian Alaska Natives do live in poverty, which is the highest in the United States of America. There continue to be high rates of smoking and alcohol use, in addition to low breastfeeding rates, second lowest, second to Blacks, African Americans. And as I've harked on many times already, that history of historical trauma, racism, leading to limited access to high-quality health care. Focusing a little bit more on SIDS and sudden unexpected infant death, some studies have found that protective risk factors can include breastfeeding, bed sharing, actually, low pregnancy smoking rates, and making sure that women have access to quality care. Factors that increase the risk of these conditions include higher pregnancy smoking rates and bed sharing. Bed sharing you see on both, and I'll definitely touch more on that a little bit later on. Also, of course, preterm birth, which some of our earlier presenters have also focused on. So goals for prevention would be making sure our mothers have safe, stable housing, and helping to decrease preterm birth, decreasing antenatal smoking, and encouraging breastfeeding. This is a quote from a tribal member. She said, "I think most of the issues that we face today in Native communities all go back to historical trauma. I mean, you have to evaluate how Indians have been treated for the past 200 years. While we may not have felt that specifically today, one, our ancestors did. So if you have done any research on epigenetics, it's literally imprinted on our DNA." Within the American Indian Alaska Native communities, 39% of pregnancies occur before 20 years of age, versus 21% of the overall US population. There's also the importance of family that's very essential to the culture, and lack of family connections can increase the risk of negative behaviors such as substance abuse. Substance abuse treatment and recovery must address complexities and the impact of historical trauma. The greatest motivation in substance use disorder treatment is to keep or regain custody of children and demonstrate their worth to family. Within the Native community, there are high rates of fetal alcohol syndrome. Among Northern Plains American Indians, they have the highest in the United States, with 9 per 1,000 births. And the Indian Health Service study reported rates of 56% of patients consuming alcohol during pregnancy within this community. The South Dakota Tribal Pregnancy Risk Assessment Monitoring System found binge drinking rates of 43% in the 3 months prior to pregnancy. And among that subset of patients and people, 65% were sexually active and not using any form of contraception. And they also were not trying to get pregnant. So prevention of fetal alcohol syndrome really starts before conception to reduce alcohol consumption for patients who are at risk of pregnancy or planning to become pregnant. Additionally, working with patients on pregnancy prevention with the history of high-risk drinking is also very imperative. For those in treatment, there was the perception of an equal care, that their history of having a substance use disorder impacted their perceived interactions with staff and also influenced the amount of pain management that they received. And this also influenced the type of birth control counseling that was received and CPS involvement. Many felt that there was an increased pressure to have LARCs, so long-acting contraceptives, such as IUDs and Nexpanons, which are devices that have to be, they're a form of birth control, and they have to be inserted by a provider and removed by a provider. So that really takes the control for birth control outside of the patient and puts it into the provider's hands. And many felt as though these forms of contraception were being forced upon them versus birth control pills, which many often preferred. There's also intersectional identities. And what this means is really a sense that those in treatment needed to advocate for themselves more than their white counterparts due to racial stereotypes and addiction stigma. And based on this, they also felt that they received inadequate care and had an increased barriers to accessing resources that they desperately needed. In regards to tools to use for counseling, one study, the Choices study, looked at alcohol-exposed pregnancies and how to prevent the occurrence of such. And they used motivational interviewing, which guides the individual to explore and resolve ambivalence about changing behavior, highlighting and increasing perceived discrepancies between current behaviors and overall goals and values. This included personalized feedback about drinking, birth control utilization, goal setting, specifically in regards to alcohol consumption and birth control, and social support, which our previous presenters have also highlighted as being really essential. And with social support, being able to identify a person to really help with those behavioral goals. Social support is typically most effective when backgrounds are similar, especially culture, since there is then an increased understanding of the stressors and surrounding environment that one has to deal with on a daily basis. Goal setting with pregnant persons and partners is also essential and is most successful at creating prolonged alcohol abstinence during pregnancy. High levels of support following residential inpatient alcohol and drug treatment leads to 3 times more likelihood to abstain from future substance use, which is huge. Also, having social support from older female relatives, aunties, mothers, grandmothers, also help to improve abstinence and also influence contraceptive decisions. So as providers, it's really important to include all of those within the appointments and decision-making. As I discussed before, so the role of family is essential. and including the male partners, and also having elders involved as well, and involving parents for those who are at risk of alcohol-exposed pregnancies, with many who were in treatment stating that prevention really starts at home. And for parents who are having these discussions with their adult children, supporting the parents in being able to have those discussions is very important at a provider level. In regard to contraceptive counseling, there's oftentimes an increased pressure to use these long-acting devices like Nexplanon and IUD. And that's oftentimes, as I mentioned before, not really what many people want. And sometimes they'll choose that, but what people want is for us as providers to explain all of the options to them and not just say, you have these two. And so that's just something to remember. Historically, the bodies of birthing people have long been sites of social control, including forced sterilization programs targeting communities of color and incentives for individuals with substance use disorders to use contraception. Studies have noted individuals of color particularly viewed LARC promotion to be racialized and connected to historical injustices, resulting in greater distrust of providers and discontinuation of recommended contraceptives, which is, of course, what we don't want. Toxicology testing is a big topic, and specifically inappropriate toxicology testing and CPS involvement, which oftentimes can lead to child custody loss and can subsequently contribute to hesitancy for people to disclose substance use disorders and hesitancy then to follow the prenatal care schedule and to start treatment. People of color and infants more likely are subject to peripartum drug testing than whites. Because of the unique legal consequences of toxicology testing for birthing people, the American College of Obstetrics and Gynecology and the American Society of Addiction Medicine recommend that testing should only be obtained with consent. Patients should be informed of the potential ramifications of a positive test, and a positive test should not be the sole factor in determining family separation. Those with substance use disorders within the American Indian Alaska Native communities oftentimes had more difficulty establishing care and felt increased scrutiny, mistrust, and expectations from providers and treatment programs, including, as I've mentioned before, the increase in more frequent urine drug screens, oftentimes without proper consent. And overall, feeling that they had different standards than their white counterparts. There was also the feeling that there was less support and attention from labor and delivery staff, inadequate pain management in the postpartum period, and they were less likely to be prescribed opioids due to history and assumption of potential misuse. And many felt the need for higher standards for methadone access compared to the white male population that predominantly visited methadone clinics. There were also CPS concerns as many observed lower thresholds for CPS investigations and custody loss, and higher standards for getting their children back compared to white families. Personal negative experiences in treatment and perceptions, as I've mentioned before, contributed to many barriers in engaging in care. And this is also seen with the punitive reporting policies with the urine drug screens that oftentimes are obtained without consent. And also the fact that some states have a policy of mandatory versus case-specific CPS reporting, which again reinforces that internalized stigma. Also, the implicit and explicit racism in white-dominated perinatal settings, and the internalized stigma and shame associated with being pregnant with a substance use disorder history, which outweighed all other factors. So lessons for institutional improvement would be increased diversity and anti-racist policies in healthcare, dedicated resources, funding for American Indian traditional resources, longitudinal partnerships with our communities, and areas for provider and substance use treatment program improvement include making sure that adequate pain control is met, appropriate contraception counseling, and really, as I touched on before, exploring all options, and making sure that there's not a disproportionate act with toxicology testing, and also examining protocols for CPS reporting and involvement. As far as success stories, many often cite spirituality, their faith, religion, as being central in their treatment programs. Also, making sure that culture is incorporated, which for the Native American community can include smudging with sage, dancing, ceremonies and powwow. Of course, if they're pregnant, we're not doing the sweats or sun dances. Also, making sure that family is involved, because family is central. And also making sure that people are connected with American Indian recovery resources, such as Wellbriety, which incorporates culture, drums, smudging, 4 directions, and talking circles, which impart knowledge through sharing personal experiences and storytelling. With providing culturally appropriate care, it's, as I've said before, important to recognize historical injustices, eugenic practices, and implicit biases in order to provide trauma-informed and culturally appropriate care and counseling. Appropriate behaviors for the community include gift giving. It's very culturally appropriate. And checking in on a personal level versus starting the agenda with business matters. So what this does is it helps to develop strong relationships with your patients and clients, and it really does support bi-directional communication. And it oftentimes doesn't take that long. Sometimes can, but it goes a long way. And also very appropriate to involve the community, especially elders, in decision-making and program development. Within the healthcare setting, really focusing on continuity of care, so minimizing the revolving door of medical providers. And so what that means is, as much as you can, having a patient client seeing the same provider versus seeing a different medical provider at every prenatal visit. Also, limiting the aspects of colonized birth experiences and placing supportive focus on mothers. And of course, it'll depend on the setting that you're in, hospital versus birthing center versus home, since many hospitals do have restrictions and policies on how a woman can birth, if she can stand, if she can sit, if she can squat. But always important to check in with those who you're working with and before you even get to that birthing stage, having a doula, of course, is very helpful and helps women to advocate for themselves in that space. And also was one of the reasons why, even though I'm a medical provider and delivered babies in hospitals, I chose not to do that because I felt more comfortable outside the hospital and I felt safer there. Okay. In regards to culturally appropriate care, actions to help lower postpartum depression, making sure that our mothers have confidence in the cultural expectations when transitioning to motherhood, supporting them during labor, especially supporting them with other women, and having that support from providers. For SIDS prevention, as we've touched on before, at a provider level, culturally appropriate breastfeeding support can help increase those rates. Also, offering balanced guidance regarding bed sharing, because I know many providers will say you cannot do it at all. But if you look at the data, you really have to look at the big picture. And also, looking at policies to limit aggressive marketing of infant formula. And also making sure that during your visits, there's counseling in regards to smoking cessation and that you provide adequate support for your patients and clients. As far as culturally specific providers in our community, of course, there's NARA. And we offer both inpatient and outpatient substance abuse treatment services for both adults and youth. And our inpatient facilities for adults also include the ability to bring your families, bring your children as well. And we also have medical and mental health services throughout Portland as well. Other culturally specific providers, more information can be found with the Northwest Portland Area Indian Health Board. And OHSU also has a great resource of rural tribal clinics at this website here. And these are clinics throughout the state of Oregon. And these are my resources, and if you are a medical provider or love to see data and things like that, I would definitely recommend reviewing these. And that's all. Any questions?
Hi, thank you so much. My name's Josh, and I know it's a changing field, but one of the questions I've had is about the concept of harm reduction in the American Indian community and questions around like MOUD resources. I feel like historically I've seen them be harder to access with some of the treatment programs, and I'm wondering where we're at with that right now.
Yeah, definitely. NAR specifically is, of course, abstinence-based, but there are many resources in the community, specifically Project Nurture, that does offer those services. And I know I saw some familiar faces, and so if anyone else has resources, definitely please chime in.
So do you refer someone out to Project Nurture if they need harm reduction? If they're not willing to do abstinence, is that what I'm hearing?
Who's that coming from?
Here. No.
Oh.
Hi, I'm Angela.
Oh, hi.
I was just asking you if what you do in terms of harm reduction at NARA, do you not do harm reduction at all? Or you refer them out?
So we do MAT, but naltrexone, which we typically don't do in pregnancy. And so if someone was wanting harm reduction, they would go to Project Nurture, for instance, at OHSU or elsewhere.
Oh, even with MOUD?
Yes.
Oh, okay. And just the second question, my first question I originally had with you was what brings you here today? Tell us a little bit about your experience and your background that interests you in the field in Native American studies.
Definitely.
Any of that?
So I work with NARA. I've worked here for 6 years and also worked at Puyallup Tribe in Tacoma, Washington as well, and just have a very strong love for the Native community.
I was just going to say, you've obviously shared what NARA is able to provide as far as folks that are in search of medication for opioid use disorder. What I will share is the experience that I've had with folks that are already on medication for opioid use disorder, and they have been able to take part in some of the outpatient services. So it's not completely like, oh, you're on medication, piss off. Like, but they may not, they don't have enough money.
Correct.
And it was like at the wellness center and not like at the actual outpatient. Sorry, it was at the wellness center, not at the actual outpatient facility.
So we offer both inpatient, outpatient services, and medical, mental health as well, and housing, dental. So we have quite a few different wraparound services.
Another resource that you're looking for, if it is culturally specific, is Great Circle Recovery does MAT treatment. They do methadone. They also have a van that will sit at PDX Saints Love on 82nd and Ash that will dose. And so if you guys need more information, you can come see me afterwards. Great Circle Recovery. And it's from Grand Ron Tribe.
I'll go. Hi, I'm Jessica. I had a question for you about, you mentioned formula advocacy for alternative feeding options. I loved hearing that from you because you're in the medical community. I've experienced some struggle advocating with the medical professionals around alternative formulas that are often oriented in like cultural or religious reasons. That someone's looking for an alternative. So I'm curious if you could give us some insight on how best to help advocate from that in a way that would actually like move some of the medical and billing things that are in place for like choosing a traditional or hospital provided formula.
I would say definitely speaking with the provider, depending on kind of what your role is with the client. Because depending on where the provider is working, I know at NARA we'd be definitely more receptive to that and trying to assist the clients as much as we could in that way. So definitely having that open communication with the provider. And if you can attend appointments with the patient, that's oftentimes helpful as well.
Do you offer services to women who are biracial, who have Native American in their bloodline and they're not pregnant?
At NARA, yes, we do. We serve all.
Since we've been talking about sharing of resources, and we've also talked a lot about the peer world, I wanted to share that there is a culturally specific peer organization for American Indian and Alaska Natives, Painted Horse Recovery. Yeah, I feel weird with the mic in my hand, but I also just want to shout out enforcing the mic thing. I have hearing loss, and so even though I just tried to talk without one, don't copy me. I need to be able to hear it through the mic. Thank you.
Yes, definitely. Okay, thank you so much.